Thank you very much for having me, and thank you for the organizers for allowing us to present our work here. I'm Clemens Schirmer from Geisinger, and I'm going to talk about the implementation of an AI-based cardiovascular and stroke prevention program. This is a little bit off the beaten path for neurosurgeons, but has been an interest of mine for the last couple of years, and has been really fruitful in terms of stepping out of our usual wheelhouse. By the way of introduction, Geisinger is a large integrated healthcare system in the middle of Pennsylvania, and we cover quite a large geography, which brings some of the challenges that we're going to talk about. We do have 3 comprehensive stroke centers and a robust stroke ecosystem, which is important for this effort. As further introduction, the status quo and the challenge here, as you know, stroke is a major problem. By the time that patients with stroke come to us, it's usually too late. We failed in another very important aspect of care, which is primary or secondary prevention. And some of the tools that we have to predict who's going to have their stroke are really poor. Some of them go back to several decades ago, are based on a few hundred patients and have been literally done with a slide ruler. Not to decry the quality of these, but also some of them give you a 10-year risk score, which is overall not super helpful in terms of turning that into an actionable intelligence when it comes to dealing with a patient right now. And of course, it behooves to remember that primary prevention or treatment is not any good without prevention. And there are guidelines for what to do with patients, but they're not very good at really distilling down to who those patients are that require what kind of prevention effort. And of course, resources are scarce. We do have the challenge between geography and efficaciousness. In an ideal world with unlimited resources, primary prevention would be the way to go, and we can lever the ideal prevention effort on everyone, but that is not really effective nor feasible. Of course, I don't have to explain to you what the burden and the impact of stroke really is. We have about 800,000 strokes in the US per year, and the impact is quite substantial, both in the population that is Medicare or 65 or older, and not. The majority of stroke patients actually occur before that age group, and also the long tail of the financial expenses of the healthcare system and also the impact on society is quite substantial. So any kind of prevention effort that is efficacious here goes a long way. We looked at some of the published work and constructed a model that is based on essentially 23 variables. I'm glancing over the details here a little bit. From the buckets of demographics and health behaviors, laboratory values, social economics, determinants of health, vital signs, and medications. And we constructed a feature vector from these things. For comparison, the ACD risk score in its original form has about 9 variables that go into this. And an important innovation here was to make sure that we have a longitudinal risk vector that is not requiring that all these components are present at the same time. So we can construct whatever the latest variable is that will be incorporated into this model. And just looking at this intuitively as a time series, you can see that on average, the patients who did have an event in our validation cohorts were different than the patients who did not. So much is very intuitive, but it sort of like just shows you that the model works a little bit. We then trained the model. We used 175,000 patients as a training cohort. There's obviously a class imbalance between the stroke and the non-stroke patients. And then we had a test set that we used to validate and come up with a 94% area under the curve, which is quite substantial. And then looking a little bit further into this model, we do have a smooth curve for the event distribution here. And we are able to make short-term predictions and look at how that compares to reality. But we also fall short in these sometimes. So, we do have so like a little bit of a leading edge here. We're able to prevent events a little bit before they happen, but we also have a lag sometimes. So overall, this is a little bit of a wash here in terms of using this as a short-term prediction. And we can talk about that more maybe in the discussion, I guess. We have since iterated the model, and I want to pull your attention to the J-score here. As a binary classifier of model, I guess, fit, across the 4 dimensions of true and false, positives and negatives. We are currently running in production a model that has an area under the curve of about 0.75, which is actually quite substantial. Here is what we have as far as our, I guess, swath of patients. So we have a cohort of patients that is considered high risk between 80 and 99%, and a moderate risk between 50 and 80%. We do have patients where we identify a care gap algorithmically. So a care gap is when you have a clinical opportunity to improve, such as you are on a blood pressure medication, but your blood pressure is uncontrolled still, so we may have to adjust your dosage, or you're diabetic with poor A1C control. Those are clinically relevant care gaps that we can work on. We can prescribe new medications, we can adjust medications that exist. But sometimes we can't find such a care gap, right? You can be, for example, very old and have a high risk, but that's not a clinically relevant or actionable care gap. About half of our patients, we are able to find algorithmically a care gap. That doesn't mean that opportunity doesn't exist in some of these other ones, but those are only usually found by manually reviewing the chart, which is obviously not scalable. And we, around this concept, constructed a program of mapping our own patients, so Geisinger insured patients, onto 7 unique care gaps that we then farmed out to our medication therapeutics management team, which is a pharmacy team that works with our primary care doctors based on these risk corridors. And we ran a 6-month pilot program from roughly November last year to June this year. These are the care gaps. I'm not going to belabor these too much, but basically these are based on the best practice guidelines that exist between stroke prevention and cardiovascular prevention. The patient flow looks like this. So if you have a care gap, we can map those care gaps. There's obviously an overlap because some patients have more than one care gap, but that is the minority. Furthermore, the patient then flows through the process here that we address these care gaps, and in some patients we're able to successfully close the care gap. In other patients that's not the case. For analysis, the baseline here looks like this. So based on your risk strata and deciles, we have certain event risk for cardiovascular events ranging from 6 to 12%. And for ischemic stroke, we have 0.02 to 0.1%. This does go up stereotypically with your risk, obviously, which is helpful to see that as an internal validation. And I wanted, for the comparison or the analysis cohort here, we looked at around 900 patients, and I want to draw your attention mostly to this cohort here of the patients where we validated the care gap and closed it and had follow-up. So everything that's green is better than the baseline. Yellow is our rates that are essentially roughly the same as the baseline. It's important to see here, or to note, that we apparently did better in the 80 to 90% decile than the 90 to 100% decile of risk. You can see the relative risk reduction in that second decile is quite substantial. This comes out to be statistically significant for the cardiovascular events, and there's a trend against the baseline for stroke events. We can also dive into certain metrics, for example, looking at lower density lipids. We had a reduction, random reduction of about 8 milligrams per deciliter in the cohort of patients that were not referred or didn't go through the program, and we did have a 2.5 times as large reduction. So an improvement in the patients that did go through the program here. This also has a financial impact. This is a busy slide, but suffice to say that we predicted that we would avoid about 140 events per year. And our current analysis is somewhat preliminary, but we have avoided in 6 months about 60 events. So that extrapolates to about 120 events per year. And that's pretty close to the above estimate, which comes out to be significant in a financial impact analysis. So in conclusion, we implemented successfully a pilot program that translates AI-based risk prediction into actionable intelligence and maps it onto known clinically relevant care gaps. In our 6-month pilot period or program, we concluded on 900 patients that we can show a significant reduction in cardiac events and a trend towards reduction in cerebrovascular strokes. It's about an 8% relative risk reduction for cardiac events And we didn't have any event or stroke event in any of the patients that we actually touched on and intervened upon. Our second iteration of the underlying machine learning model is promising and needs to be explored further. And we'll probably have to switch it out under the hood, so to speak. And then our financial impact analysis seems really promising and needs to be also vetted some more. With that, I'll take any questions. Hope this will stimulate some discussion. And again, thank you very much for having me and for this opportunity.